Okay, whoa. All right, we're good? That sounded really loud and echoey. All right, let's try that. Okay. It's my honor, and it is the final time that I will be standing here as the chair of the Grand Rounds Committee to welcome you to our Grand Rounds series. I'll be handing off my chair duties at the end of this academic year, and I feel like we definitely want to hear and save time, but I want to make sure I get some thank yous out just to acknowledge. So first and foremost, thank you, Dean Lynn, for trusting a fairly new faculty member with this endeavor and letting me lead it for the last 4 years. It's been a joy of mine to be able to host Grand Rounds and to identify speakers and to bring our faculty together. I also want to thank the numerous Grand Rounds committee members who've served with me, helped me identify speakers, come to events, particularly Dan Whitaker, who has been a cheerleader in the corner helping me think through all of the logistics to make this work. Special thanks to Sam and Jordan, who have helped me and helped us make sure that we are marketing this talk so that people show up and join us online. I hear in particular that our virtual presence is pretty high and that people are going back to watch our Grand Rounds lectures, which is really exciting. And then I want to thank Anne-Marie Scapani. She's not here, but she has agreed to take on the chair position. So hugely grateful to her so that I have somebody trustworthy to hand this over to. And finally, I think I've thanked Marcus every single time I'm up here. I know that he does not like this attention, but essentially Marcus makes me look really good. So I get the fun of identifying speakers and working with them and having my name up front, and it is Marcus that does the hard work of making sure that flights happen, cars arrive, hotels are scheduled, food is there, and all of the pieces in place. And so I want to give a huge thanks to Marcus. It's been a joy to work with you, and I think he already knows that I've identified 6 other opportunities to be able to continue to work with him in other capacities. But the reason that we're here, as a second-year law student, I cited a paper titled Of Swords and Shields by Professor Mello. I had no idea who Mello was at the time. I just saw the word Mello show up and be cited over and over again on a second-year paper. Some years later, we won't count how many, this is still the title of the paper I remember citing the most as a law student. And if you would have told second-year law student Jelaine that she would be standing here at the microphone introducing Michelle Mello as a Grand Rounds speaker, I would have probably pinched myself. Additionally, if you would have told me that I've had the opportunity to work with Michelle as a collaborator and a mentor, I probably would not have believed you. Michelle has a number of exceptional achievements that I will not belabor here, but she has a joint appointment as faculty both in the School of Law and Medicine in the Department of Health Policy at Stanford. To say that her publications are robust would be an understatement. She clearly and truly sets the gold standard for legal scholars who are making impact in our field. She has a seamless way of identifying emerging topics and publishing things so quickly that I honestly don't know if she sleeps, but I know that she does. But most importantly, personally, I'll say that to work with Michelle is genuinely an honor. She is an incredibly insightful collaborator. She provides feedback that is really fine-tuned. She's also got this knack for asking questions that really keep you on your toes. She's also been an incredible mentor and an advisor, and I'm always honored to get the opportunity to have time with her, and we are just so thrilled to have you here. Thank you so much, and Michelle, I'll hand it over to you.
Well, what a wonderful introduction. Thank you so much, Jelaine. I think one of the solaces of aging is that you get to see your students grow up and become leaders, and I really appreciate any solace in that department these days as I weather middle age. Thank you very much, Dean Lynn, for having me, and also for hiring Jelaine and taking a chance on a weirdo. Lawyers in the School of Public Health are not so common, and it's not an easy path to tread, so I really appreciate that investment. I want to talk today about a topic I've been spending quite a bit of time thinking about in connection with work that I'm doing at Stanford. I run a lab there called the Healthcare Ethical Assessment Lab for AI. that does ethical assessment of tools that Stanford hospitals are thinking about using. And one of the things that's bubbled up on our radar screen is that an increasing number of these tools relate to billing and insurance, which is, a bit of a snooze fest at first, but actually I think once you get under the hood, as with all things related to AI, really, really fascinating set of political economic dynamics going on, as well as technical questions. So I want to share some of the learnings that we've had in this space and some reflections on where things might be going and what is colloquially referred to as this arms race between healthcare providers and health insurers to try to win the battle of billing and reimbursement. This topic has actually been in the news quite a bit recently because the lawyers have gotten involved. There have been some well-publicized instances where insurers have been using AI tools, have made decisions to deny a care request that a physician is making. The patient has had a very bad outcome in certain cases, and there have been lawsuits. This is the one that has gotten the most publicity, largely due to some really interesting investigative journalism at STAT, involving a company called NavaHealth that had a product that would help insurers assess requests in concurrent review processes. So you're in a rehab hospital, for example, your physician thinks that you need to stay longer. The insurer is going to approve or deny that request, and this algorithm reportedly helped them do that. Because of these kinds of lawsuits, which include now some big lawsuits against several of the major insurers, policymakers have gotten really interested. When I talk to federal and state lawmakers, there's really two issues they want to talk about relating to AI. One's mental health chatbots, and the other is this one. What are health insurers doing with algorithms? So there have been hearings in many states and repeatedly in both the Senate and the House on this issue. Senator Warren definitely has a bee in her bonnet about it. And CMS has been activated around this issue as well because these issues have bubbled up to the fore, especially in Medicare managed care plans or Medicare Advantage plans. So let me talk a little bit, give a little bit of background here. When we're talking about these AI tools, I want to separate three contexts in which they are being used in insurance right now. One is in just regular claims reimbursement. So your doctor gives you a service, then they bill for it in our fee-for-service system, and the insurer decides whether to pay it or not pay it. There are opportunities in that space of retrospective review. Second is the concurrent review context that I've already talked about. So things like, post-discharge hospitalizations, drugs that people have been on for a long time that they need to stay on, have to get re-upped for approval every so often. So there are these kinds of review processes as well. But the process that I want to focus on today is the third one, prior authorization. So just this down. It's pretty intense. And that was a mistake. All right. So we've probably all been privy to this process as patients. Your doctor wants to do something for you in the future, and before they can do that, they have to get the insurance company's approval. When they say no, we get these letters in the mail called explanation of benefits letters that we then struggle to decipher and challenge. And that's the space, again, where there's been the most activity in the AI market and where I want to focus on. So why do we have these processes in insurance? The insurers defend these processes, which everybody hates, by pointing out that we have a fee-for-service system still predominant in the US. Providers get paid more the more they do. And so these are really essential processes for detecting and deterring overuse. Deterring by creating these procedural barriers to getting your thing done. Perhaps you'll think harder before you want to do the thing. And indeed, there are lots of areas where we know we have low-value care, or in the drug space, lots of drug therapies that probably work just as well or usually work as well that physicians might not reach for initially, but might if they had to go through some extra hoops to get the more expensive drug approved. In the present administration in particular, there's also a great concern about fraud and abuse, that there are some bad apple providers who do seem to be billing an awful lot for services that probably are not medically necessary and might not even be provided at all, might be outright fraud. And so these kinds of processes help detect these outlier providers and take action in response. And of course, at the end of the day, we should all want that because we have to pay insurance premiums. And when costs go up, insurance premiums go up. So physicians have a very different perspective, though, on prior authorization. This quotation comes from a colleague of mine at Stanford, sort of sharing his perspective on the purpose of prior authorization, which is not to weed out unnecessary things, but to throw up lots of procedural barriers and essentially effectuate a rationing by ordeal scheme. The American Medical Association has for decades kind of had a campaign against prior authorization. This is from their most recent survey of 1,000 physicians, where they're really trying to drive home the impact of this process on patients and on physicians and its contribution to burnout. So in this survey, which is of course very unscientific, most physicians report that at some point or another, prior authorization has led to delays in care for patients that have been clinically impactful. And almost everybody says, look, this is helping push me in a direction of feeling really burned out with medicine. Finally, a majority of physicians don't think that the advent of the AI revolution is going to make things better. They're worried that it's going to make things worse in this realm. So I wrote a paper about these dynamics. I sent it to a former mentor of mine who had left academia to run a big insurance company. And I was quite critical of the use of this process and the way it had become so prevalent. I think I managed to offend him more with that paper than any other paper I've ever shared with him in 25 years. He wrote back a very reasonable set of comments, but it included this quotation, sort of defending the insurance company's perspective. And I'll just pause for a moment. So really speaking about the need for a bulwark against physician overuse and defending the process itself as being quite ethical, driven by people who are trying to do the right thing and who are doing it really extraordinarily quickly, given the volume of information that they have to process. But people tend to focus on the worst case scenario in this process. So there is definitely this battle of perspectives around prior auth. I sort of tend to reconcile these perspectives by thinking about this as the best bad idea we've had for controlling healthcare costs. I don't know if any of you have seen the movie Argo, where they're talking about getting these diplomats out of Iran during the hostage crisis, and they sort of toying with a number of ideas. Can they get them out on bicycles? And the one they land on is to create a fake movie and go and send in a fake film team to extract them. And this is described as the best bad idea that the CIA has come up with. And again, I think that's pretty close to where we are with prior auth. It's the worst idea we can imagine, except for all the other ideas, like narrow networks of physicians or cutting reimbursement or just outright rationing. So if we're going to do something, the question is, how do we optimize that process, the best bad idea? And that's where I think the conversation has shifted to technology, to AI. So when the National Association of Insurance Commissioners surveyed large insurers last year, and the great thing about being the NAIC is, as a regulator, you can make people respond to your survey. That would be awesome. So they got 93 large insurers to respond across the 16 states that fielded this survey. And the headline here is they're really getting into AI. If we look in particular at the large employer group market, 70% of those insurers are using AI now or will be within the next year. So it's becoming pervasive across insurance companies looking to improve this process, which they know everybody hates. So the question is, can we make it better with AI? Is that likely to happen, or is it likely to make things worse? I think there are a number of reasons to think that we might gravitate towards either of these futures. I want to share some of the reflections from this paper that my team published in Health Affairs recently. This, again, grows out of the work of my lab in actually evaluating on the ground several of these insurance-related AI tools at Stanford Healthcare. So what are we doing with AI in this space first? And then what are the reasons to think it might make things better or worse? There are markets for AI tools that are for insurers, And there's a separate market for tools that are for healthcare providers. So we got two sides in this arms race, and they're each being armed by the vendors. These tools that are insurer-facing do a number of different things. Some of the tools are just matching tools. So an insurance company has coverage criteria. The tools are just looking to see if those criteria are met. Is the person on the health plan, for example, and is this the kind of situation where we would approve this service? Then there are a range of predictive tools, like the one that was the subject of the lawsuit over rehab care, that are designed to project a patient's healthcare needs and therefore inform a decision about whether to approve this next thing. There are tools that actually embed in them what the vendors call nudges, so the physician can be encouraged to prescribe certain drugs, to take certain clinical actions that are efficient for the health insurer. So they will actually guide a care path. And there are tools then that process these requests and can automatically issue decisions very rapidly for those that are approvable, while routing more complicated cases or a non-approvable, what seems to be a non-approvable instance to a human review. All insurance companies have to have these medical professional reviewers. They have to take a look at these cases before they're denied. And then finally, some of these insurer-facing tools use generative AI to actually draft the explanation of benefits letters that we all receive to explain the decision. Now, on the provider side, a health system like Stanford might receive sales pitches about a variety of different tools. Some of them can tell us when a particular service is subject to a prior authorization requirement for a given patient, given who their insurer is. They can verify whether the patient seems to have coverage for that condition and service. Some of the more sophisticated ones then can put together the request by sucking information out of the electronic health record, including drafting a paragraph about why something is medically necessary, inferring things from providers' notes and diagnosis codes. Then suppose we get our request denied. Well, even though we employ currently about 150 people whose full-time job it is to deal with prior authorization, we don't have enough manpower to appeal every denial. So we have tools now that can tell us which denials are most likely to be reversed if we appeal them. And then finally, there are tools that can draft that appeal letter, can look at what the insurer said, and then go back into the EHR, find information that might be helpful in mounting a successful appeal. So this is like a soup to nuts suite of tools here that can conceivably deal with every aspect of this process, which again formally takes up so much of providers' time that they're saying that it contributes to burnout. I think that there are actually a number of reasons why these tools might be really helpful. And reason number one is that the current situation is terrible. There's just no discussion about prior auth that doesn't include the word sucks at some point in the conversation. Everybody hates it. And anytime we start with a human-driven process that is that bad, it seems like technology is at least worth considering because the counterfactual is really suboptimal for everybody. But there are, I think, substantive reasons why we should think AI might be helpful here. One is that in the present situation, we know there are a lot of mistakes. And we know this because when people appeal these, which is not very often, when they do appeal them, we see overturn rates of 20 to 50, sometimes even 60%. This is probably not because insurers are uncaring or sloppy. It's just that this involves digesting a very large amount of information. And insurers are doing this using people who probably don't have vast amounts of clinical training and cannot access the electronic health record. So they're reliant on whatever the provider tells them. And so it's a situation that just leads to a lot of mistakes. The reason that we get so many rejections is very often that the requests are incomplete. Again, this is because the insurer cannot go back and try to fill in the gaps just by looking in the patient's medical record. They don't see those records. So it's whatever the provider or the provider's assistant put in the form, and very often it's just incomplete or missing information, and very often that's because the 150 people that are submitting these requests are not the doctor At a large health system, they are people who may have a high school education. They certainly don't have clinical training. They're doing the best they can with a very complicated electronic health record. But stitching together a paragraph about medical necessity from a provider's sloppy notes can be really, really hard. So even if we could just get at the problem of like incomplete submissions, we might make huge progress in trying to reduce the rate of denials. It's also true that even though the policy conversation is always focused on the denials, most of these prior auth requests, they get approved. You know, upwards of 90% of them, sometimes as high as 95%, depending on the plan, are going to be approved. And they're going to be approved because there's not much controversy about whether medical necessity is met. There's a clear coverage determination criterion, and really what the reviewer is doing is just saying, does the patient have the condition that we approve this thing for? That's just a matching task. AI is really good at that kind of thing. So if we're interested in like reducing delays in patient care, there's huge opportunity here to just auto-approve a bunch of stuff that we were going to get to yes on anyway. Then there's the response letters. So has anybody received an explanation of benefits letter? Anyone received? Yeah, I got one recently. I think I'm pretty well educated, and I could not make heads or tails of it. You know, they're terrible. They have this very like boilerplate language that's inserted by some non-AI algorithm that really doesn't tell you very much about specifically what was it about your case that led the insurer to say no. You get some general thing like, oh, you know, you needed to try a different therapy first. With generative AI, there's a prospect of easily generating much more detailed, informative letters of explanation. And that, in turn, could make it easier to appeal. Because if you don't know why your thing was denied, how are you going to appeal it? So for all of these reasons, I think there are potentially big improvements in this process if we let AI tools in. And I'll just say, some states have been really reluctant to do that. There's been more than one state where legislatures have proposed outright bans on the use of AI in health insurance coverage decisions. And again, it's a really lost opportunity when you have a system that's already so flawed. Okay, but I'm an ethicist. I have natural skepticism about anything that might hurt patients. So let me talk about some of the challenges that we're encountering in protecting patient safety in this area. The number one issue is the one highlighted in these lawsuits, which is that although there is putatively a human that is reviewing these AI no's before they become official no's, there are real questions about how meaningful that review is. The statistic that the lawyers in this Nava Health lawsuit cited is that reportedly, like in stockholder calls, the insurance companies brag about how use of these tools has reduced the average review time for prior auth requests to under a minute. Now, we're statisticians, we know that's probably averaging over like a whole lot of yeses and a few more time-consuming no's, but it doesn't look good, and it really raises questions about how long is the human actually spending and what are they bringing to bear. What worries me is that more than likely, the AI, when it gets to a decision that it's not approvable, is curating up a nice little summary of the case for the human to review. That creates all kinds of opportunities for framing bias, affirmation bias. And the way I sort of thought about it was, I was writing this paper while I was grading exams. I thought, what if my teaching assistant had pre-graded all of the exams and stamped them with a grade and like a sentence or two about why she thought that was the right grade? I'd probably approach that evaluation task differently than if I just got a blank exam to grade. I'm going to be affected by this predetermination. And in the same way, having these curated files for human reviewers may be pushing them in the direction of agreeing with the AI more often than would be the case if they just got fresh de novo review. And then, of course, as the lawyers will point out, you layer on all these organizational incentives for the reviewers to agree with the no's. This has really come up in some of the reporting by STAT as well when they've interviewed some of these reviewers and former reviewers at insurance companies that describe enormous pressure to conform to algorithmic recommendations, that, like to the extent that some of them even had like a target, like 90% of the time or more you need to agree. And so really having a difficult time moving off the default decision that the AI has teed up. So figuring out how to have humans involved in the no's in a way that is meaningful, really tricky. That problem is compounded by the fact that the people who are involved may have very low familiarity with the AI itself. So if there's one thing I've taken away now from spending a couple of years evaluating these tools is that we have organizationally like enormous faith in individuals to be good overseers of AI output. You know, we think they're going to think carefully before they accept it, and they're going to check and all these things. But we don't really empower them to understand what might be wrong with it. And if they don't have that kind of knowledge, it's very hard for them to be good supervisors. It's hard to know what to look for. When we interviewed folks in our health system who were tasked with using these AI tools to submit these requests and appeal denials, you know, we found many of them could not tell us what generative AI was, much less how it works, how it's trained, what the error modes are, like hallucinations. And they hadn't been trained in this by our organization. So again, if you don't really know what to look for, you can't be a good overseer. And that's a particular problem for tools that use reinforcement learning, meaning they look at how the users interact with the output, how they rate it or what they change about it, and then they learn how to get better in the future based on that user input. That's a great idea, but it requires that your users are good overseers and provide feedback. And if they can't do that, either because they don't know what to look for, they can't recognize errors, or they just don't have the time or incentive to give that feedback, that reinforcement learning actually might lead you in the wrong direction, where the algorithm concludes, oh, I'm awesome. Nobody changed anything here. With predictive AI, there's another problem as well, and that is that it's very hard to see inside these algorithms. Whereas with rule-based prediction models, like we're all familiar with from our regression analysis classes, we know exactly what the X's are. With machine learning, you never really know for sure. At best, you might get from the developer a list of the top 3 or 4 most influential variables that led to a prediction. So if you're thinking about yourself as a physician or a patient who's trying to appeal one of these decisions where somebody said, we don't think you're going to need additional rehab care, for example, how do you know what to press on if you don't know what drove the decision? Another challenge arises from kind of familiar problems with model underperformance in AI. One of the big things that comes up when we're predicting care needs is that because all these models are just trained on the electronic health record, they don't include a lot of determinants that we know affect people's care needs. For example, this algorithm that predicted how many more days of rehab somebody needs had no information about people's social supports at home. Kind of an important factor in understanding whether it's safe to discharge them from a rehab hospital. But without that in the EHR, the algorithm developers are kind of flying blind. So we're likely to get a lot of underperformance problems for certain kinds of predictions where the variables just aren't captured in our data systems. Then there are familiar problems about the representativeness of the data on which these algorithms are trained. For example, if you've got an AI tool that's trained on a very different mix of health plans than the one that your hospital is dealing with, who's to say as to how good it would predict something like which denials are most likely to be overturned? And finally, drift over time is a special problem in this area. Insurers' coverage policies are changing all the time. The algorithms may not be able to keep up with that. And an even more interesting problem is that all of these models are trained on data that came from a system operated by humans. So a human was submitting the request and a human was adjudicating the request. We're now moving into a world where it's a bot talking to a bot. So will the performance of these algorithms drift away from being high because they're now living in a world that looks actually quite different? And also, are they going to be learning from other algorithms in a way that causes them to drift away from the outcomes that our values would like to see in the system? We've encountered a few instances in our reviews of some kind of perverse incentives and unintended consequences for these algorithms, especially the predictive ones. So the example that comes to mind most readily is this algorithm for predicting which denials we should work on appealing. That algorithm was trained mostly, I think, on an insurer's past history of paying for that kind of service. So if you're an insurance company and you know this, what is your incentive? You're going to deny and deny and deny and deny, because the more you deny, that algorithm will learn you're not worth tangling with. you are not going to change your mind. So it will push our hospital away from even trying for you. That's not the outcome that anybody intended. But again, in a system where everyone's just following their incentives and learning the best they can from the systems that we have, that's where it will go. So what do we do about all this? It is, from a lawyer's perspective, a really wicked problem to try to deal with from a regulatory perspective. One problem is that in the private sector, where most of the regulation of AI responsible use goes on right now, there's very uneven governance practices. This NAIC survey of insurers found that 40% admitted, probably some didn't admitted they don't have any processes to measure and accept accountability for errors in their AI algorithms, like a governance committee or a monitoring system. Most hospitals themselves still don't do local governance of the type that I've been describing, where we sort of evaluate a tool and how it's working. 1 in 4 of these insurers say they don't have any ways of studying after deployment model accuracy or drift. And we're living in a world where there's not a lot of monitoring or governance going on either side. And even among the insurers who say, oh, we're definitely doing a lot of governance, see, we have this committee and this advisory board, the speed of adoption of AI tools is sort of mind-boggling. So one large insurer, again, on a conference call with shareholders, has admitted to having over 1,000 active AI use cases in operation. 1,000. Even a very large corporation, I think, would have a very difficult time monitoring how 1,000 different AI tools are operating, whether they're effective, whether they're making good decisions, how often they make mistakes, how to train people on them, and so forth. So very uneven landscape for private governance. So what about formal regulation? Well, the problem here with insurers, as most of you know, is the responsibility for regulating them is really fragmented. There are some plans that are regulated by states. There are other plans that are ERISA plans, and they get regulated by Congress and Labor Department. There are still other Affordable Care Act marketplace plans that have a different regulatory scheme. Then there's the VA, there's Medicare, there's Medicaid. So it's not straightforward to just kind of pull a regulatory lever and have it trickle through equitably to everybody in the system. But the biggest problem, I think, is just substantive. Even if I could pull a lever, I'm not sure what lever I would pull to guarantee more meaningful human review. How do you write a law that guarantees that somebody in an insurance company meaningfully review a denial before it becomes effective? Really hard to figure out how to legislate that. So what legislatures have been doing instead, and CMS to some degree, is adopting disclosure requirements, saying to insurers, you need to say what you're doing with AI, and you need to say something about how often you deny prior auth requests and how often you overturn denials when they're appealed. And that's really useful information, but unfortunately, none of these disclosure requirements connect the two. So we can have them say, here's what we're doing with AI, and they can say, here's how often we deny care, but nothing enables a researcher to understand whether AI is making things better or worse. So are the denials concentrated in situations where they're using AI or not? Who could say? So I think there are some obvious recommendations that would address each of these problems, incrementally. I think the single best thing that states could be doing right now, as well as organizations like the Joint Commission that are doing accreditation, would be to say to health systems, you need to have some kind of governance process for AI, and it should meet these kinds of standards, and we're going to audit you to make sure that you're doing that. It's certainly not watertight. It leaves a lot of room for organizations to have lax processes or just anemic ones. But can you imagine, for example, a system of human subjects research that didn't have that requirement? We do that for human subjects research. You got to have an IRB, needs to do these 7 or 9 things, and we're going to audit you every so often to make sure that you're doing that. Nobody wants to go back to the good old days where there was no IRBs except maybe the PIs that have to submit those applications. So I do think it'd be an effective first step to start requiring these kinds of processes. As to the fragmentation point, the good news about insurance is that there is already this very active organization called the NAIC that's this consortium of insurance regulators. They have quite a bit of power. They're really smart people, and they might be able to do a lot of coordinated action across the states. We also have a pretty good set of rules around this for Medicare Advantage plans that could be a model for other kinds of plans. I think the best thing that insurers could do would just be to quit using AI to tee up denials. So I believe them when they say there's a human in the loop that reviews it before it becomes final, but I sure wish that they were getting that fresh final exam that wasn't pre-graded by AI. And I also wish that insurers would start disclosing more information about how AI is implicated in particular decisions, including both approvals and denials. If they really believe that it's making the system better, they should be willing to provide the data that enable independent researchers to evaluate that. So let me conclude with a few thoughts on what is ahead. I think if there's any good news, it's that insurers recognize they got a problem here. They've got a political problem, they have an optics problem, they've got lawmakers breathing down their back to change these processes. And so they're trying to get out in front of that. Last summer, they issued a big press release through the America's Health Insurance Plans, the big organization of large group insurers, saying, we're gonna do a bunch of things to try to improve AI processes. The one that impressed me the most as having promise was reducing the scope of prior authorization. Which means, as they just clarified in a follow-up communique this month, cutting back on the number of services for which prior auth is required, recognizing if we say yes almost all the time, like, what are we doing here? Giving some providers kind of what they call a gold card, a free pass. If their requests routinely get approved, they don't have to submit them anymore. They've proven that they're not a bad apple, they're a good apple. We're not going to waste time. And other things to kind of streamline the process of applying for prior authorization, such as, if you've got your expensive drug approved, maybe it doesn't need to be reapproved every 90 days. If you've got cancer, you need to be on a long-term immunotherapy. Chances are you're still going to need to be on that immunotherapy 90 days from now. So maybe we don't need to keep requiring you to get continuing approval. There is also a sort of looming expansion of the use of prior auth. So at the same time that we see the insurers making some noise about right-sizing their use, it's expanding in a domain where it has very infrequently been used in the past, and that's for Medicare beneficiaries who aren't in Medicare Advantage plans. Use of prior auth is pretty universal in MA plans, but it's been rare in traditional Medicare fee-for-service plans. That's changing. The Trump administration has introduced a 5-year pilot program called the Wasteful and Inappropriate Service Reduction Program, or WISER, where it has contracted with technology companies to begin reviewing certain services that it has identified as being low value or susceptible to fraud and abuse. It's a small list, and it's relatively uncontroversial. It's things like knee arthroscopy, where there's pretty well-established evidence base for alternatives, or things where there's an insane amount of utilization, like skin substitutes. They're very expensive products. And there are things for which there are clear coverage criteria, but this is just a pilot. The intent is to expand it. And it's got people like Alexandra Ocasio-Cortez really exercised, because the reimbursement model here is that the tech companies will capture a share of the savings from denials. So this is not sort of a flat fee, but providing an administrative service. It creates incentives for them to say no. There are safeguards in the system, like if the denial gets overturned, they don't get a share of that savings. But historically, only about 1% of denials get appealed. So even though the overturn rate can be really high, the appeal rate is really low. So people are very concerned that essentially what is being done here is bringing AI into a sphere where there's never been prior auth at all, and having it done by companies who have direct financial incentive to say no as often as they can. And then finally, the third kind of great frontier in this area, and where I'll close today, is kind of in a different battlefield, which is around billing. So I've been talking about what happens before services get rendered, but remember, an important component of utilization review is this retrospective review of billing that has already been submitted for services that have been rendered. And here too, there is just this huge growth in the market of vendors offering AI tools to arm both sides of this battle. So there are vendors that are marketing intensively to hospitals like ours, tools that will find diagnostic codes that our physicians forgot to bill for. or will suggest a different coding intensity that results in higher reimbursement. Our team has started calling these no-code left-behind tools. And they do this by scraping the medical records in many cases, but also in some cases by listening. So the ambient listening tools now will record your clinic visit with your physician. These transcripts can be used to find keywords that would support higher billing codes or additional billing codes. And then on the insurer side, there are all kinds of tools that help them combat these practices, which they view as fraud, by detecting weird things that are going on in coding. To be clear, this battle has been going on for a long time, this upcoding battle. But this is a new tool in the arsenal, the machine learning algorithms. Interestingly, Blue Cross Blue Shield hired John Wenberg recently to spearhead this report. It was pretty widely publicized, finding a kind of explosive growth in coding intensity in some very concentrated areas. And when they look to see, are the patients getting services that are commonly associated with having this health condition or this intensity of a health condition, the answer was no. So they were seeing a growth in the codes, but not in the actual services that suggested that the patient had the thing or had the thing as badly as it was coded to. Now, they couldn't directly connect this to use of AI, but it just so happened that this uptick coincided with the advent of a lot of these billing tools, and the researchers were speculating that this was what was responsible for these concentrated blips in coding intensity. And the cost to Blue Cross Blue Shield was really high. In maternity care, for example, it was a 22% increase over this period. So really high stakes here for both sides, and a landscape that just shows explosive growth in all kinds of uses of AI tools. So where are we going to end up here? I mean, I think there are definitely two versions of a future. In the sunny version, insurers use these tools to make prior auth less painful for us all and for physicians, to get to yes faster, instantaneously in many cases. We can provide prior authorization at the point of care, to improve communication with patients and providers about why they're denying care, and to make it easier for them to submit prior authorization requests and to get them overturned if they're erroneous. The darker future is that they use these tools to supercharge a process that's already deeply flawed. It's overused. It results in useless barriers to care seeking. It frustrates physicians. And now, whereas this process used to cost $40 or $50 an instance to do a prior auth request, now it's virtually free with these tools. So it makes it cheaper and easier to apply prior authorization to a huge range of services where it hasn't been applied in the past. And given the opacity of some of the algorithms, it's possible that it might have the adverse effect in terms of facilitating appeals and getting to the right answers. It just makes it harder to know why the algorithm has said no. The tricky part is that insurers have incentives to go both directions. They should want to get to a place where they're saying yes at the lowest cost possible and keeping clients happy. But they also do have these incentives to keep costs down by saying no in cases where they think it's wrong. So it's really unclear which path we're going to be led down. And the fact that we don't have a lot of governance or regulation in place does not help get us down the right path. I think having more oversight within hospital systems, within insurance companies, but also through regulation is going to be essential to making sure that this arms race leads to constructive outcomes, not destructive ones. Thanks very much. I'm very happy to take some questions. I think we have some time.
Thank you. This was really great. I'm wondering if the denials, if they're seeing any patterns that emphasize racial bias or other biases that could have been baked into the system from past historic and systemic racism in medical practice generally.
Yeah, it's such an important question. It's really, really hard to answer because, again, based on the things that I have observed, you just don't get that kind of information in the sales pitches. Even when the answer is good, they're not inclined to educate you about what kind of subgroup testing, for example, has been done. Some organizations now do monitor that afterwards for some tools, and some states require them to do that. So in California, for example, we actually have quite strong algorithmic discrimination laws that require our hospitals to say, here's all the algorithms that we're using. We have made a reasonable effort to determine that this kind of thing is not going on. But I think there's much more that can be done. And if you are a developer, it starts with having enough clinical partnership to understand when there are things you cannot measure in your tool that are going to be important to that patient's outcome. So the rehab example of social supports is a pretty clean example of that. And just acknowledging up front, like, look, we can't factor this in. We think it's a great algorithm. I think it's to be really helpful. But your people need to be looking for physician notes about social supports at home because we cannot put them in the model. And of course, all these structural determinants are going to have impacts, especially for tools that are predicting a person's ability to survive in the wild, for lack of a better term, without direct medical supervision.
Thank you very much for your talk and for your work over at least the past 20 years. I've been following it. One of your articles about public health law and approaches to the problem of obesity is still a reading in one of my classes, and that was, I think, in 2006.
Thank you.
You've covered a lot of territory since then. I'm struck that this conversation, like the conversation around electronic health records, ultimately boils down into a dollars conversation, not a access and quality and outcomes conversation. And I'm wondering, particularly when it's about 30% of care that's been assessed as being either inappropriate or unnecessary, whether AI, as you understand it, is also being integrated in a more meaningful way in terms of decision support and kinds of things more earlier in the process that would avoid looking for authorization for inappropriate or excessive kinds of treatments.
Yeah. Well, I suspect that you're a primary care expert, I believe, and I think you probably have more insight into that than I do. But I'm certainly aware that some health plans are very interested in these care pathway tools. That I described one of them that's in use at a plan that it has a lot of risk bearing itself, the provider network, so it has incentives to do this, but will help the provider see at the point of care what the options are, what the prices are for that patient, what the costs are to the system, and can suggest a treatment option that is higher value or lower cost. I think many primary care physicians have concerns about the trustworthiness of those recommendations when they are coming from a payer. So figuring out how to do that in a way that garners their trust, for example, by basing them on clinical practice guidelines from organizations that they already trust. I think that's important. But yeah, I actually think that would be quite promising. I think all of us as patients probably continue to observe that if we're relatively well insured, the physician seems pretty indifferent at the point of care to cost. I mentioned that I got one of these EOB letters recently, and it was for a drug that was prescribed by my provider, where there was another drug that was also highly effective, much lower cost. Kind of hard to justify. She just had good experience with that drug. And this replicates itself millions of times, and we end up with a lot of care that we could define as wasteful in the sense that the patient would get an outcome that's nearly as good or as good at much lower cost. So there does seem to be upside, and to me, again, not a primary care physician, but the trust issue seems to be the main thing that would be holding physicians back, along with just I think they're not in the practice of checking the EHR for prompts in the course of making, in the last 2 minutes of the visit for treatment plans. The hospitalists are a little easier to capture in that regard, but the primary care docs, I think, are not in the practice of that, but they could be.
I would say more cost drivers are being driven by specialists, hospitals, than what's going on in primary care, although clearly there's a connection relationship.
Yeah, and there's options there too. And again, I think in many ways they're easier to implement in the hospital setting and in the specialist setting. So, even things like open evidence that are keeping specialists acutely up to date on the latest evidence about different therapeutic options can be super helpful if we're choosing an oncological therapy for a particular patient population, for example.
Hi, sorry. I don't know if you already mentioned this because I kind of came late, but I was wondering, who do you think should be accountable when these systems fail?
Yeah, I have a lot of thoughts about that, as you might imagine as a lawyer. Um, we don't have a lot of signals yet from the court about who is, like, descriptively, in fact, being held responsible. But my sense as both a scholar of malpractice law and as somebody who thinks about and sees how these things are getting rolled out is the physicians are always at the pointy end of the stick, and the nurses, I was saying this to the students I was meeting with beforehand, we tell them, at the end of the day, you have to use your clinical judgment to decide how to react to this AI suggestion, whether that's a visit note or a treatment recommendation. You're supposed to validate it, you're supposed to check through the source documents before you accept it, you're supposed to make sure that's right, edit it, all the things. And if you don't, it's your license at the end of the day. And the health system, in many situations, is going to be the one that actually pays that bill because the insurance arrangements it's all bundled in together. But physicians do not like having a settlement against them in the malpractice system. And I think at some level it's really unfair that much onus is being put on them. The other point of unfairness that I am seeing a lot and want to do more thinking and writing about is the contracts between the AI developers and the health systems. So we see repeatedly the developers just put all these disclaimers in there. We're not going to be liable. We're not giving medical advice. You're giving medical advice. This is just a tool. And we're even disclaiming like common warranties about the product doing the thing that it's supposed to do, which we don't, by the way, don't let any other product maker do. They're not allowed to do that by law. All these disclaimers go in there. The health system attorneys either don't push back or can't push back. And so we enshrine a de facto allocation of liability where the developer does nothing, and everything, again, gets shunted downstream to the users, which seems super unfair. And it happens because it's not banned and because they have good lawyers. Yeah, Dr. Massad.
Thank you. So a lot of your presentation was really focused on this idea that everybody agrees prior authorization sucks, right? And yet you made a compelling point a couple of times, particularly when you were talking about your previous mentor, who's now in an insurance company, who's like, number one, there's a reason we need prior authorization. Number two, it sounds like the overwhelming majority of times it's working and it's working right. And so without even considering the application of AI, prior authorization has a messaging problem, has a public perception problem. Yes. And so then we layer AI on top of that, and now we have
two things that people love to hate.
Right. Yeah, yeah, exactly. And then we have a bugaboo to blame. Yeah. So yeah, I don't know if I'm struggling with exactly what the question is there, but it seems like there's also this additional piece. Like, how do we fix that and clarify? There's a legitimate public benefit to even the concept of prior authorization and how AI can help. And I think you gave a couple of great examples of that, of how it can facilitate faster results when there's a really straightforward answer and that answer is yes, or, I don't know if you want to just comment.
Yeah, I've thought about that some too. I think the insurance industry is actually trying really hard to help people understand why they use this process, and that most of the time it works pretty well from the patient's perspective, not maybe from the doctor's perspective, but most patients get what they need in a reasonably short period of time. I think it's a messenger problem. You and I talked a little bit about messengers before this session. When that's coming out of the insurance company, it's kind of hard to buy, especially if you're the one out of 50 who has gotten one of these crazy letters. So I think the question that I have formulated out of your observations for myself is, isn't it in their interest to share more information with external people who might be in a position to be other messengers? So if indeed because they seem really confident in these positions, and indeed they might be right. They are sitting on a lot of data. They're getting something out of it, but they don't share And I think unless they're willing to be more transparent about that, it's going to be hard to convince physicians and patients that they are operating a system that has a lot of warts, but is working pretty well, and we lack an alternative that they would prefer.
I think my question is also a little bit ill-formed. I'm trying to figure out why an AI algorithm for making those prior authorization determinations is not a medical device legally and not regulated as a medical device. Kind of thinking about, like on the AI side, like Doctronic needed special insurance and all of that to be able to operate. So why are the AI tools on the insurance side not
great? So FDA's current interpretation of medical device, which is its own interpretation of a 1976 statute, is that it needs to be making a clinical decision or a decision that influences the health of a patient if it's like a direct-to-consumer tool, and without human in the loop, basically. So even for tools that are actually making treatment recommendations, it's only a small subset that qualify. There are some other things that are in as well, like stuff that's in radiological tools and image processing, that kind of thing. But for these decision support tools, it's really a very narrow tranche of them. And then, so this is like a step removed. It didn't make the recommendation. It's just evaluating whether it meets coverage criteria. So that to me is like clearly out of even the most roomy interpretation of where they can go. So we need some other kind of form of regulation, or we need a change in the statute if we would like FDA to do that. But most people say FDA shouldn't really be in the business of regulating things that insurers are using as administrative tools. That's not what they're good at.
So as long as we keep that human in the loop assumption.
Well, that's what works for them on the clinical side. So again, as long as it's informing a treatment recommendation and the doctor has an opportunity, like has enough time, et cetera, to evaluate that before they act on it, it can get exempted from intensive FDA review. Again, they can tweak that definition. Not really inclined to do that right now. But in a under different leadership, that's a possibility for them. But I still don't think it's going to reach into insurance tools and other administrative tools. And I think that's probably just as well. There are other ways to do that governance that I think are going to be faster, more localized, and better.
Could you talk, I don't know, I know you're not a legal expert on other countries, but are there other nations that are doing healthcare provision in a different way where this issue is being addressed, like where they have a universal healthcare system that is better at managing how these are being integrated into their systems, or is it pretty much the same?
Yeah, I really don't have a lot of specific knowledge on the coverage approval side, but they don't really, prior auth it's not uniquely American, but it's mostly American. There are very few other systems that use it, and certainly that use it to the extent that we do. They might do it in a different way, that is, because there's only one payer. When a new drug is available and it costs a lot, they'll decide, is it in or out for the whole health system? And but that's a coverage determination. It's not a prior authorization requirement. So they just tend to do things differently. Now, of course, they're using AI for lots of other things in clinical care. They have different ways of regulating it. Of course, there's a lot of variation from country to country, but some countries have gotten in the business of AI regulation pretty intensively, including the UK. And to the extent that people are worried about privacy issues or catastrophic risk, the European Union. And their general approach has been to adopt a risk-based framework where they designate things as either high risk or not high risk, and then really impose quite a few requirements if you're a high-risk thing. This tool, under any definition, would be these AI tools that I've been talking about, low-risk tools. So even under that framework, they're not going to qualify. These administrative tools won't qualify. But a lot of these administrative tools really do have a lot of impacts on patient care. It's actually been a struggle for me, even in my own hospital, to get them to acknowledge that things that, like, designate who's getting blood stocked in the operating room before a surgery because they're at transfusion risk, or allocate beds during flu season. These can have important impacts on patients' degree of risk in the hospital. But the counter argument is like, look, we've got a list of AI tools waiting for approval as long as my arm. So we got to like focus our oversight on high-risk tools. Thank you very much.